So I'll be discussing first is definition of so my plan is to discuss about the definition of thyrotoxicosis, etiology, pathogenesis, morphology and clinical features of thyrotoxicosis. So what is the definition of thyrotoxicosis? It's a hypermetabolic state caused by elevated circulating levels of T3 and T4. Obviously T3, T4 is more, TSH will decrease except for secondary hyperthyroidism where TSH secreting adenomas can be there. So this definition you should make sure is a common definition, I think, for all, universal definition. It is a hypermetabolic state characterized by increased levels of T3 and T4. So you should not get confused with two terms here. One is the thyrotoxicosis and the hyperthyroidism. Hyperthyroidism just means hyperfunctioning of the thyroid gland. You got it? So hyperthyroidism means hyperfunction of thyroid gland. Although majority of the causes of thyrotoxicosis is caused by hyperthyroidism, sometimes they use interchangeably. Okay, so hyperthyroidism means, as the name suggests, is hyperfunctioning of thyroid gland. Thyrotoxicosis is more of a hypermetabolic state. Okay, hypermetabolic state having increased levels of T3 and T4 associated with hyperthyroidism. So primary cause, the effect is in the thyroid, which is Graves, toxic MNG, adenomas, then iodine-induced hyperthyroidism, neonatal thyrotoxic. This is all primary cause of thyroid gland. Second is TSH secreting adenomas of the pituitary. So other causes not associated with hyperthyroidism is inflammation of the thyroid, that is thyroiditis, which is granulomatous, lymphocytic and other rare causes like struma ovary and factitious drug induced, that is overdosage of L-troxin. So I will be discussing the morphology and pathology only these three conditions. Why? Because these are the three commonest conditions of thyrotoxicosis. These are the three important and commonest cause for thyrotoxic. So what are the commonest cause? One is Graves' disease, toxic multinodular goiter and toxic follicular adenoma. Okay, what is Graves' disease? So this anyway will be dealt by both of us, me and sir. So Graves' disease is the most common cause of hyperthyroidism. It is a triad of features. What are the triad of features? One is hyperthyroidism. That means in Graves' disease, the thyroid gland is diffusely secreting more of T3, T4. The entire gland is secreting more of T3, T4. Okay. So diffuse proliferation, diffuse hyperplasia of the thyroid gland with increased secretion of T3, T4. Okay. That is the first one, hyperthyroidism. What is the second triad of Graves' disease? Ophthalmopathy. What is the ocular lesions in the Graves' disease? What are these ocular lesions? I'll discuss. Third one is the skin changes in the Graves' disease. That is called dermopathy. Although acropathy also is there, that may or may not be there associated with Graves' disease. What age group it is commonly affected? 20 to 40 years. And females are 10 times more prone for getting this disease, that is Graves' disease. Pathogenesis. This is where you should know why these diseases come. This why question comes in pathology. Okay, any disease why or what comes in pathology. So pathogenesis is what progression of the disease. So obviously the Graves' disease is an autoimmune disease. It is what? Autoimmune disease. So autoimmunity means there should be some antigen, there should be some autoantibodies, right? So where is the antigen here? Antigen is nothing but the TSH receptor. So what madam discussed, the TSH receptor, all the antibodies, majority of them are targeted towards this TSH receptor. Okay, there are some mice studies also. If these patients, in some of the mice studies, if they inject TSH receptor, some of the mice having a genetic mutation associated with HLA-DR3, which is associated with Graves, has autoantibodies against TSH, they develop Graves' disease. So this is experimental study where mice is injected with TSH receptors. They have HLA-DR3 mutation, which is associated with Graves' disease. They have Graves' disease progression. So HLA-DR3 is associated with Graves' disease. Okay, so these patients with Graves' disease, they secrete autoantibodies against TSH receptors. One type of autoantibodies are called as thyroid stimulating immunoglobulins. Okay, thyroid stimulating immunoglobulins are nothing but IgG antibodies. And second type of autoantibodies is thyroid growth stimulating immunoglobulins. These thyroid growth stimulating immunoglobulins stimulate the follicular cells to proliferate more. Okay, they stimulate the follicular cells to proliferate more. There's another one, autoantibody, which is TSH binding inhibitor immunoglobulins. Although these immunoglobulins, the name is inhibitor, they function as TSH stimulator only. They keep stimulating TSH, so obviously more of T3, T4 will be secreted. So all these three immunoglobulins, they function as TSH, thyroid stimulating hormone. They stimulate the thyroid for proliferation of or secretion of T3, T4. So one is a thyroid stimulating immunoglobulin, the another one is growth stimulating and inhibiting. So some patients of Graves, that is why it is explained, some patients can have hyperthyroidism, some of the episodes of hypothyroidism also. They'll be having Graves' disease, sometimes they get hypothyroidism. This explains these two antibodies. So these inhibitor immunoglobulins can cause sudden hypothyroidism in some cases of Graves' disease. Because of this, so ophthalmopathy, this is one of the important triad of Graves' disease. Okay, so if almost all cases of ophthalmopathy, the cause is Graves' disease. The secondary cause, even it's the primary cause, other primary cause, usually ophthalmopathy is not seen, almost not seen, very, very rare. Okay, so if you see ophthalmopathy, rule out Graves' disease almost always. Okay, what is ophthalmopathy? Here they'll be having a wide stare look with the lid lag. The upper palpable or upper part of the cornea usually is not visible in a normal person. If it is visible and there is an elevation of the upper eyelid, that means a wide staring look, that means the patient has ophthalmopathy. Sir will discuss how to test for ophthalmopathy. Some patients can have protrusion of the eyeballs, that is called exophthalmos. Okay, exophthalmos, if you see, you have to rule out Graves' disease, which is commonly associated with that. So why this eye starts to protrude? What is the cause? Pathogenesis. So these are some of the explanation given in for the cause of ophthalmopathy. What are the causes? Why this eye starts to protrude in Graves' disease? One is infiltration of retroorbital space with mononuclear inflammatory cells. The lymphocytes keep on infiltrating in the retroorbital space. The second pathogenesis associated with that is there is edema and swelling of the extraocular muscles. There is edema and swelling of the extraocular muscles. There is accumulation of extracellular connective tissue, extracellular matrix, usually hyaluronic acid and chondroitin sulfate. There is fatty infiltration also associated with this. So these are some of the genetic cause for pathogenic associations associated with exophthalmos. Now coming to gross. So that is morphology. You know, morphology means include gross and microscopy. Gross means naked examination, how a Graves' disease thyroid gland looks like. It is usually diffusely enlarged, and the cut section or a gross appearance, it looks meaty. Okay, when you see a meat, very red fresh meat, how it looks like that. Okay, so diffusely enlarged thyroid with meaty appearance. Okay, beefy red, they say beefy red, meaty appearance. This is a microscopy of Graves' disease. So microscopy, as it's a primary hyperplasia of the follicular cells, you see there is you saw the normal histology of thyroid. Okay, you see follicular cells, parafollicular cells. Folliculars are usually cuboidal. Okay, here they proliferate more and become columnar. They become what? Columnar. Okay, because they proliferate more, they form pseudo papillary hyperplasia. They proliferate and cause these pseudopapillae. So there is inward projections like this, pseudopapillae, inward projection of these follicular cells. And one important feature you see in this Graves' disease is this indentation, or we say colloid scalloping. Okay, some part of the colloid is resorpted in these hyperplasias, that is in the Graves' disease, where some vacuoles form here, so that colloid is lost with the indentation which is called as colloid scalloping of the colloid, and colloid becomes decreased in these Graves' disease. When these proliferate, okay, all the colloid is utilized for proliferation. There will be stratification here. Stratification means crowding of these follicular cells which are columnar, they become crowded, they proliferate, there is hyperplasia, inward projection, that is pseudopapillae, lot of pseudopapillae. So these colloid becomes decreased and there is colloid scalloping. This is a common, colloid scalloping is a common feature for all toxic thyroid condition. The second commonest cause of primary hyperthyroidism is what? I told you, toxic multinodular goiter. Okay, so toxic multinodular goiter, how they present? Usually these patients are have swellings varying in sizes. They can have a huge thyroid swelling which can go retrosternal, can go and compress the trachea also, it can cause symptoms like that. So these patients suddenly they get toxic symptoms. They may have palpitation, tachycardia, other toxic features associated with this. So obviously these patients will have many nodules, not like Graves which is diffuse. These have multiple nodules which can involve single lobe or can involve both the lobes or can involve the isthmus also, can also present with solitary nodules, single nodules. So multiple nodules. Okay, so gross of multinodular goiter, how it looks. See, you see varying size nodules. Can you see this varying size nodules grossly, how it looks? Okay, sometimes cystic change and colloid cyst and all can be associated with that. Okay, so microscopy, you see these large varying size colloid follicles filled with colloid. Some places hyperplasia takes place and these scalloping and decreased colloid formation takes place. So this is a foci of hyperplasia which is secreting more of T3, T4 associated with. The third commonest cause of hyperthyroidism is a neoplastic, that is adenoma, toxic adenoma. So in an adenoma neoplastic, this is the normal thyroid tissue grossly. There will be well encapsulated lesion. Okay, well encapsulated lesion. This is different from the normal thyroid tissue. When you see microscopically, it is a capsulated mass. Okay, you see these thyroid follicular cells, which is the neoplastic part, which is quite uniform compared to the other adjacent compressed thyroid follicles. So this also can secrete more of T4, which is the third commonest cause. So now next is the next and last part of what my discussion is the clinical features. So clinical features, as madam gave an just outline like how the patients of hyperthyroidism can present. If you know the normal function, if it functions more, it is hyperthyroidism. So the function is due to either hypermetabolic state or overactivity of sympathetic nervous system. Okay, so it is the symptoms are due to increased or hypermetabolic state and overactivity of sympathetic nervous system. So because there is increase in BMR, what happens? How the patient will be? Because of increased BMR, the skin will be soft, it will be warm and it will be flushed. There is heat intolerance and increased sweating in these patients. There will be weight loss despite good appetite. They'll have good appetite, but they'll be losing a lot of weight. Okay, this is an important feature of hyperthyroidism. Okay, the skin will be soft, it will be warm and it will be flushed. There will be heat intolerance, increased sweating associated with weight loss. This is an important findings associated with increased. What are the cardiac manifestation of hyperthyroidism or thyrotoxicosis? These patients will have, as madam already discussed, there will be increase in cardiac output. There will be tachycardia, palpitations, cardiomegaly. If the patient is susceptible or some comorbid condition, if it is not treated well, they can go for congestive cardiac failure. The patients can have arrhythmias. These are the commonest complications associated with hyperthyroidism, arrhythmias. Then neuromuscular system, these patients can have tremors, hyperactivity, anxiety, inability to concentrate, insomnia. There may be myopathies associated with thyrotoxicosis, thyroid myopathy. That is thyroid myopathy. Ocular changes we discussed. What are the ocular changes? We discussed that wide staring gaze, lid lag, exophthalmos. It is all comes under thyroid ophthalmopathy. In GI system, it can cause hypermotility, malabsorption and diarrhea, which is due to sympathetic overactivity. Skeletal system, these patients can have osteoporosis. So this, the volume of the bone or the trabeculae can thin down, and there may be multiple pores. The bone may become weak. There may be probability or more susceptibility for pathological fractures. These patients, hyperthyroidism, can have pathological fractures. What are the other findings? The muscle can be atrophic. The patient is usually, because of loss of weight, the atrophy of the muscle, he looks very thin. There may be other lesions in the muscle like fatty infiltration, lymphocytic infiltration, fatty liver may be there. And one important you should remember is in Graves' disease, there may be generalized lymphadenopathy due to lymphoid hyperplasia. One of the complications of hyperthyroidism is thyroid storm. You should remember this. These patients suddenly can go for acute exacerbation of these increased secretion of T3, T4. Okay, sudden increase of T3, T4 in some of the stressful conditions, like if the patient is having some infection, if the patient is going for surgery, if the patient suddenly stopped antithyroid drugs, suddenly they can go for some crisis. Okay, some complications. Okay, this is called thyroid storm. Okay, so this is usually associated maybe due to increased adrenaline surge. The catecholamines may suddenly increase and cause these complications like this, which is called as thyroid storm. This is a medical emergency, should be treated immediately, admitted in ICU, and if patients are not treated, they may go for arrhythmias and the patient may. So another type of hyperthyroidism you should know. Not all cases of thyrotoxicosis, the patient will come to you with the classical findings like tachycardia, hypertension, dermopathy, exophthalmos, all that. Some patient will not present with the classical signs and symptoms, especially elderly patients with comorbid conditions. They may not present with a classical picture or a classical clinical finding of a thyrotoxicosis. Okay, so this is called apathetic hyperthyroidism, which is seen in elderly. These patients can have comorbid condition, can mask the classical features of hyperthyroidism. So this you should remember. In elderly patient, unexplained weight loss, you have to rule out hyperthyroidism, check T3, T4, TSH levels, rule out hyperthyroidism, unexplained weight loss. One of the cause for hyperthyroidism where the patient may not have any toxicity even after having more of T3. So that finishes. Just for summarization, we'll discuss with some 5 MCQs which I have